Out of nowhere, I was walking outside, grabbed the front door, and I couldn't breathe. Within 10 seconds, I was massively short of breath. I was diaphoretic. That means I was sweating like crazy, pale. I was weak. I barely made it to my chair. I was alone. Nurse Wendy was outside. She came in within a minute or two, thank God, saw me. I told her to call 911 because I'm having a pulmonary embolism. In my case, massive clots shot up into my lungs and could have died, guys. Being on testosterone, did that exacerbate this at all? Because I really want to do a great video on this. So if you go for hip or knee procedures like you should, right, stay healthy, are you at risk from dying from a pulmonary embolism like I almost did yesterday?
I'm Dr. Thomas O'Connor, a lifelong powerlifter, board-certified physician, and published academic author. I've taken care of thousands of men on testosterone and steroids, and now I use my media appearances in this YouTube channel to provide education and harm reduction. Subscribe now so I can help you stay strong and healthy.
My pulmonary embolism, man, it was rough, guys. What happened and what can you learn from this? Today's date is September 2nd, 2025. I had a hip surgery in July, and a few days after that, it was July 13th on a Sunday, 2025. I had a massive pulmonary embolism out of nowhere, guys, and I'm here to talk about it. It was really scary. It's been a few months, well, almost 2 months now, and I wanted to put together a video exactly what happened so you guys can learn exactly what to prevent and potentially for yourself. Because if you're going to go for any surgeries, if you're going to go for a hip, you're going to have a great life and you're going to get a hip redo or a knee redo, just, you know, replace this stuff, kind of, so to speak. Your doctor, you and yourself, your doctors are going to have to think about the consequences for a blood clot. It's venous thromboembolism. It could be a DVT. In my case, massive clots shot up into my lungs and could have died, guys. It is what it is, and I'm here to talk about it, and I'm here to give a breakdown. Definitely did a lot of research for this, so this video is going to teach you about the mechanisms of venous thromboembolism and what can happen, how to assess the risks, and what are the management criteria, because I did a lot of really expert work on this. And this is up my alley, guys. This is really the interface, if you will, this medical topic, which is venous thromboembolisms and pulmonary embolisms. This is an interface of medical and surgery. Okay, so general surgeons and medical doctors, this is where we meet, right, in the hospitals on this topic right here. So what happened, guys? I had on 4 days after having my total hip redo, where they hack off the top of the femur, they hammer in a new socket into the pelvis, and they clip everything back together. It's a construction site. There's a lot of swelling, there's a lot of bleeding, there's a lot of inflammation. We're going to talk about Virchow's Triad, what happened, and then 4 days later, out of nowhere, guys, it wasn't just like it slowly happened. I was walking outside, grabbed the front door, and I opened the door, and I couldn't breathe. Within 10 seconds, I was massively short of breath. I was diaphoretic. That means I was sweating like crazy, pale. I was weak. I barely made it to my chair. I was alone. Nurse Wendy was outside. She came in within a minute or two, thank God, saw me. I told her to call 911 because I'm having a pulmonary embolism, because I knew I wasn't having a heart attack, because I'm on all these protective mechanisms, right? So I was like, I can't have a heart attack. And I wasn't having a heart attack. I was having a pulmonary embolism, which is similar, right? It's kind of a similar feel. Short of breath, diaphoretic, and weak, right? So we called 911. Grace of God, I love you guys so much. First responders, in my book, you got to get raises. You got to get more love, more attention, and everything we can for you guys, because you guys save lives, right? In the streets 24/7, and it's not without risk either, right? Working with some dangerous people out there, dangerous circumstances with blood disorders, you know, HIV and hepatitis C and all this kind. I had a patient recently that was a law enforcement officer, was bitten by someone that has HIV and hepatitis C, right? Had to take the prophylaxis, right? This is not a joke. It's very serious. God bless these guys. So my sats were in the 70s. The guys came in and I said, guys, I'm having a pulmonary embolism. They knew I was a doctor. One of the guys actually was a fan. Love you so much, man. So he's just a big jacked up dude. He, funny enough, knows who I am. And I said, that's the doc. He says he's having a PE. Check a sat. So we did a sat monitor. Sure enough, my sat's on room air as they were slapping on the rebreather to me with just full oxygen. But he checked it right before in the 70s. Yes, pulmonary embolisms, bilateral in the pulmonary arteries, and I was sucking wind. So heart rate was up in the 150s, that despite being on bystolic, you know, my heart rate sits around 60 to 70, right? When I step on the gas and I'm exercising, it goes up maybe, I don't know, 120. If I'm cranking hard in the mountain bike and training like a banshee, it will go up there. But it's like I was sitting in the room. So that was obviously my heart was having this massive response, right? So it's a massive stress response. So let's talk about what happened, guys. I was transported to the hospital, right to the hospital right away. CT angiogram, bilateral PE, both sides, submassive, without the right heart strain, because you got to have right heart strain. Vital signs were stable because of my meds. They couldn't believe it, and I was stable. They started me right on heparin to get a therapeutic, old school stuff. Really, nothing's changed. They sent me to the doctor said, because of everything, she's like, look, we have a doctor at another neighboring hospital that can do a thrombectomy, which is they can go in there surgically and remove the thrombus and the clots. She said, you know, you got a lot of clot load in there, and we're worried if any more comes, man, you're just going to be, you're going to die. Not to mention, can you remove those clots and back off the strain on the heart, because my heart's going to have to pump against that. And it's just something that if they could do it, they would do it, but it's itself risky. Long story short, the next hospital I was transferred to, I had to go to another ambulance, which was crazy. It was a massive downpour, rain in South Florida. You guys know what it's like in the summer. And the guys were driving crazy to get me there with a siren. They bumped someone. I saw the car wipe out in the back. I mean, I love these guys so much. And I didn't think I was going to make it. I thought I was going to crash in my second ambulance. The first ambulance to the hospital, I barely remember because I was kind of near passing out, and I was begging the Lord to not have me pass out, knowing that if I was going to pass out and lose consciousness as I was having a massive PE, I know it wasn't going to be a good prognosis. So with the grace of God, thank you, God, for allowing me to still be here today and to come back stronger than ever. Lungs are good. I'm strong. I'm benching again, and I just can't tell you that it is what it is, but I'm gonna tell you exactly what I'm breaking down my own risks. So they didn't do the thrombectomy. The doctor looked at me and said, man, I think you're so stable. Your heart's great. I don't want to go in there and grab that thing. I think you're stable. 5 hours later, we looked at it, and he said the clot burden, it's all shot up already because we did a Doppler and everything was gone. They couldn't see it because it all went up. I mean, this is, again, it's complicated, but if you guys that are medical people know that they all shot up, and there was a certain amount, X amount of clot burden, and it was just enough for my lungs to absorb, and it was enough where it really set me for a loop, and it was massive, and I got through it. I didn't have a heart attack because I can't have a heart attack because my heart's protected because of all the medicines that I take. That's a secret for you guys. So you want to kind of be able to tolerate a PE or some kind of a trauma just in case and not have a heart attack. That's my ABCDs, right? Look at the heart. So, okay. So I walked out of the hospital on Xarelto. I'm going to be on it for 3 months, and I'm going to transfer to Eliquis. We're going to talk about that because I got some new data. So let's go into it, guys. What happened? I had a blood clot, man. Massive blood clot shot up. It was provoked because of the surgery. Let's talk about it. Never had one before. Virchow's Triad. This is real medicine from the 1800s. Virchow's Triad. This is, again, interface of medicine meets surgery, okay? So Virchow's Triad. So what's going on? I was provoked. Which is not, if you have a pulmonary embolism or a DVT and it just happened spontaneously and that we couldn't find anything, that's unprovoked. That's the hypercoagulable workup. You know, that's really, really genetic. Testosterone, steroids, we're always wondering, could that happen from the red blood cell stuff? We're going to get into that in a minute here. So if you look at, I thought everything, guys. I've been studying this one for you guys for weeks and weeks and weeks. I've done hours and hours and hours of research for this, and I've talked to some doctors on this too. So Virchow's Triad, we got to start with the risk. That is the underlying physiologic mammalian risk, where you have venous stasis, that's slowing down state of the venous blood flow, even slower than veins are flowing anyway. And then we have vessel wall endothelial injury. trauma to it, and then the hypercoagulable state. So that's the moons lining up, and those moons lined up for me, and I'm going to break that down for you guys. So let's talk about it. So let's talk about my risks. Now, when you look at risks, we don't just wing it. It's not just willy-nilly. There's something called the Caprini score, right, for venous thromboembolism, and that's very complex. And you could put that in Google, check your Caprini score. You'll see men, women. You'll see pregnancy state, past DVT state, surgical state. It's just a laundry list. Now, I'm going to go beyond Caprini. I'm going to do what we look at for just a personal evaluation of me. I'm using me as an example of what went wrong. Where are my risks, plus and minus, right? So number one risk, guys, pay attention to this, and you could see this fitting into the guidelines for yourself, right? I'm here to give you actionable, really good information so you work as an educated consumer, patient, and then you work with your own healthcare providers, either my healthcare providers, which are testosteronologists, or of course your own. And if they don't understand this, and if they're looking at you like you got two eyes or two heads, you better have two eyes. It's been a long day, guys. So if they don't understand this, or they're just kind of winging it, like, you don't need to worry about that, you got to get another second opinion. I don't care what part of the world you're in. So again, this is internal medicine, general surgery. They have to know all this stuff. And then the pre-op doctors, this is really internal medicine, hematology, pulmonology, chest surgeons, cardiothoracic. There's an interplay of a lot of doctors that really know this, okay? But this is old school internal medicine. That's why I really felt like, man, did I make a mistake? Shouldn't I have been on more of just than aspirin and some TED stockings? But I did the research, and my doctor, I do respect him. I was a low risk, but was I a low risk? I was not a low risk, but this is just hindsight's 2020, and this is beyond the data, okay? Because I'm going to give you the data right here in the end. That's the standard data. My doctor technically didn't do anything wrong. But I know for me, my assessment going forward, because I want to probably have another few surgeries. I'm living to 110 with the grace of God and all the poodles. So of course I'm going to have more surgery. So I just have to understand my risks and what to do to prevent this ever happening again, catastrophe. Here we're going to do it. So what are my risks? I'm getting older. That's a risk, but I've never had a blood clot before. You'll see the risk starts around 40, starts to go up. Testosterone, is that a risk for blood clots? Very, very tricky and controversial. Typically, no. But we look at the JAMA data that says in the bottom line, is testosterone a hypercoagulable state? No. Does it transiently, when a man, for an example, goes on testosterone, we see that if he's going to have a blood clot, this is not provoked, this is unprovoked. Okay, I had a provoked one, but do I have risks underneath that are hypercoagulable that are not provoked? You understand that? These are the moons lining up. Okay, this is internal medicine right here. So is it? And the truth is, it can be. We have to be honest, guys. We have to be scientific and honest. We don't have data that shows exactly what to do for every man on testosterone. We have some more great data. Testosterone now looks safe for men with heart disease, right? The Travers trial, but that itself showed some increase in blood, in a hypercoagulable state. You could fact check that. And also some renal injury. You could fact check that. But those are secondary outcomes. You're with me, guys. I'm giving you a proper assessment. This is statistical stuff where it's not perfect. This is like legal. You're in the court and you're hashing it out with the other attorney, right? You're just brilliant and you're using your data, but it's not perfect. So you got to make your assessment for yourself. The educated patient consumer is going to be the winner. I don't care who you are. That's why you got to pay attention to this. So these are the risks. So getting older, testosterone, there is some residual risk. I believe it now. But it's not directly related to the red blood cells. Let's go into that. AIE, don't call it polycythemia vera. That's an embarrassment. It's a blood cancer. It's not polycythemia vera. Polycythemia, I don't really want to hear that. It's androgen-induced erythrocytosis with or without excessive erythrocytosis with the red blood cells on hemoglobin hematocrit. I donated blood, which I never do, about 2 months before, maybe 6 weeks before the surgery, because I said, I want to make sure I go to the OR. I want to have perfect bloods. I don't want the pre-op doctor to say, oh, your red blood cells are too high, can't go for surgery, or the orthopedic surgeon. So I said, I know what to do. I'll make sure I'm low enough. And sure enough, I was 17 and 52. My iron studies were perfect. So for all you guys who say, oh, he's on steroids or testosterone, or you're going to say that I was on Jardiance and that increased my red blood cells, erythrocytosis, which is controversial, which I think does play some bit of a role itself for AIE on top of this medication. But did it lead to my blood clot? You can't. How can you say this? It's multifactorial. But again, I'm adding it to the list here to be super thorough and really, really cerebral for you guys. You're never going to get this anywhere in the world. I know that. So this right here shows you that I didn't have a risk when it comes to the CBC. The RBCs were normal. Everything was normal. And I never give blood, but I did just to keep it down. So, I mean, what really was I? Was I dehydrated on that lab? Can I just drink some more water and take that 52 down to 48 or 50? You could. Okay, so the AIE was not really a controversial risk. Testosterone, controversial residual risk, because I slowed down. I usually take a little Masteron if I can get it from a doctor, right? In Europe, I have doctors all over the world that take care of me. Little Nandrolone here, Deca, and I do baby doses sometimes. And I thought, I'm going to stop that, because not to mention the erythrocytosis, I didn't want that to be a condition and a concern, so I want to slow that vector force down. So for months before, I'm just on a little testosterone, my 100 every 5 days. So that wasn't a risk, right? Is it a risk? I'm on testosterone. COVID, very interesting. I've never had the vaccine, but I had the real heavy duty COVID before the vaccine in the end of 2020, and I was really sick in the hospital. I went in there and they evaluated me. They were going to keep me in the hospital. They said, you're doing pretty good, right? You're pretty stable, doctor. So vital signs are good. I think we don't want you. You don't really need to come in the hospital. So we have IV. I said, do you have the intravenous immunoglobulins that President Trump had, right? This is when he had that. Remember this? And I said, I want that. And they said, we do. You're the first patient to have it in this hospital. I signed a bunch of papers. It took a few hours. They had to talk to the attorneys, and voila, they give me IVIGs. You could fact check this. Not that I was one of the first patients, but I was, and they had it. It was someone else's immunoglobulins that were pooled that were going to be given to me to help me recover over COVID. Did that have a response? Did that have residual effect on where I was today, pushing for my hypercoagulable state? Because we know that COVID and or the vaccine, going to the politics, guys, the vaccine, I think, was a mistake that they pushed it on people so much. I'm going to say it. I feel safe about it now, thank God. And it can be a hypercoagulable state. For how much and how much damage, I just don't think we don't know. It's water under the bridge. Especially if you've had COVID or the vaccine, you make a decision for what you're doing going forward only. You can't go back. So, but it does lead potentially to hypercoagulable states. It's strict conservative data. And did that play a role with me? It could. This is all the risks on top of Virchow's Triad. So now Jardiance, for you guys you saw the video I did with the sodium glucose co-transporters, either miracle drugs upon other drugs that are miracles, and I like to use miracles. If we have them with the grace of God, I'll use anything. I don't care, supplement, behavior, diet, medicine. I'll use anything to stay strong and healthy, and I'm giving it to you guys. That's just how that's the future. That's the now. That's biohacking, okay? So Jardiance, did it increase erythropoietin with hypo? It potentially does increase the red blood cells. I got it, guys, and I knew that before I did the video. I just didn't want to mention it in the video because I thought it was too esoteric, but obviously some guys are like, you guys are smart. Now, do we have conclusive data on it? No, we don't. Does it happen to me? I've been on it for 6 months. Not looking at my labs, not my RBCs, but again, where's the line in the sand? Is it 16.8, 17, 50, 54, 50? You're not going to find a line in the sand. You're not going to find a consensus. There's no outcome studies on it. It's all one man per man risks. Again, I love Jardiance. It does increase erythropoietin. It probably does it through hypovolemia because it causes some hypovolemia. Obviously, it's kind of like a little diuretic where you're losing glucose through the kidney and sodium, and that's actually the mechanism that's protective in part. And then the response, you can have hypovolemia. Hypovolemia can you can have hypoxemia, and it will lead to increase in erythrocytosis. I'm just telling you. I'm just telling you it's true. Now, I love that medication, so I'm just going to have to work around that. The last thing is I had massive swelling and bleeding, and that was provoked, right? But for me, I had massive swelling and bleeding because my bones are so strong, guys. I'm so put together. Thank you, Mom and Dad. And so the guy was like, they broke blades on me. So I still have pain. I had massive response, just a horrible response, I think. And that was just the stasis, that was the swelling, and it led to the Virchow's Triad. Maybe when I'm looking at all the stuff here, I'm just going overboard for you guys. Another thing I did that's really important is 10 days prior, they tell you stop supplements and fish oil. Well, I take Vascepa, which is a pharmaceutical grade eicosapentaenoic acid. I love it for inflammation. I love it for heart protection. You could see the Reduce It trial. I stopped that, and now that thins the blood to some degree, and methylene blue. Okay, that has the effects on the erythrocytosis. Guys, this is a deep dive for you. But again, by me stopping that for the surgeons, did it put me at some risk for hypercoagulable state, right? Did it put me in that Virchow's Triad hypercoagulable state? Guys, I'm doing this just for you guys. So I don't know if I would do that again. I would probably stay on it. I don't know, but then what do you do? Don't tell them? And then maybe they're not going to take you to the operating room because they see that as a risk for bleeding. So you're either going to be thinning blood versus bleeding for hypercoagulable state. There's going to be thin blood versus thick blood. I'm telling you, we're in the middle here somewhere, guys. We're trying to find the middle. My ABCDs are always perfect. That saved my life in the end because I didn't have a heart attack. I was able to suffer through a massive PE with all these symptoms, and my heart rate was cranked. My adrenaline was up, and I didn't have my arteries, with the grace of God, are wide open, and it was proved, right? And I don't want to be a wise guy, or I don't want to be arrogant on that, because I want that. What happens is, to so many people, why PEs are so dangerous is because if the PE itself doesn't block and cause circulatory collapse, because your blood is just blocked, it can't circulate through the lungs, you don't have any circulation, you have your circulatory collapse. Can you see that? You're closing off you're circulating blood through the heart. Your right side of the heart pumping up, and it freezes up in the lungs. You're done. Nothing gets to the left side. You have no pulse. Your heart stops asystole. You go through bad time. Your heart goes into first dangerous rhythms, ventricular rhythms. And if you have unstable plaque in the artery, with the grace of God, if you have it in there, you're going to have a heart attack. So I remember being a resident in the hospitals in the Northeast. We have PE, MI. You could fact check that. So as I was going through it, I was like, please, God, let the clot burden come up and just stop. This is enough. Please, no more clots, because I knew a lot of clots shot up there, and they were just in the pulmonary arteries, and they were just anchored. And I was like, no more. Please, God, no more clots. Tell me they all went up. That's enough with the blood clots. That's enough. I'm okay, please. And I was like, I can't. Am I having a heart attack? Can I have a heart attack? And I was like, I can't have a heart attack. And I did not have a heart attack. How great was that for me to get through that, to know that? I want you guys to be able to get through traumas, or God forbid anything, and because if your heart is so sound, you don't have to even think about it. You could shovel snow and have a damn heart attack. How ridiculous is that? That is something that should be prevented. Okay, check your heart, ABCDs. Now, let's get back into what the considerations are. I went through this whole thing. These are my risks. You understand the age, testosterone, androgens, the erythrocytosis. I stopped my protective potential blood thinning supplements, right? Vascepa and medical, and the methylene blue. COVID, I had it. What are you going to do about it? I had the IVIGs. Jardiance, I love Jardiance. Does Jardiance worsen the red blood cells? In the red blood cells, the erythrocytosis, does that indeed set you up for a hypercoagulable state and a blood clot? You gotta follow me, guys. This is super advanced, and we don't have data. Like, hey, there's a study where we have this and that. It's just all theoretical right now. You just have to think, what is your risk, and then what are you and your doctors doing about it? Okay, so my doctor had me on aspirin 325 twice a day and TED stockings. It's on the spectrum of what's therapeutically potentially there, recommended. The American College of Chest Physicians, does have that on there. I think if you do a deep dive across the board with other surgeons and everyone, you just look at the whole 9 yards, you'll probably see that a guy like me with all my risks should have been on a little bit more, okay? But I'm being very respectful to my doctor. He didn't do anything wrong. He doesn't see these risks. Even for men on testosterone, I just had bad luck, he thought. But again, was this my bad luck? What did I do? Was I at risk? And should I have been on more aggressive venous thromboembolism, okay, a prophylaxis? Okay, this is, again, internal medicine meets surgery. So this is the American College of Chest Physicians. You could fact check this. They do recommend the aspirin and the TED stockings, but if you do a big deep dive on this, especially with AI, because it will give you all this, AI is amazing because it just gives you ask a question. When I ask a question, I know exactly pointedly what I'm asking, and then it just gives me all the it just puts it together and gives me all the data. It gives me all the reference support. So then with my experience, I can make a decision like, wow, maybe this, maybe that. There's controversy on this. I could tell you as I wrap up here, there's risk versus thinning the blood too much, then there's going to be bleeding risk. And my doctor told me nightmares of bleeding on the knee surgeries, on the hip. People are ending up bleeding. They're in the operating room. They go to the ER, and then they're opening up, and they have these horrible, bleeding issues. It's just a mess. So you really want to have the specificity of design, of prevention, knowing the data. Okay, now again, for me and my data, I'm going to change things for myself. And if you're like me and you're getting older and you want to replace joints with surgeons and you're on testosterone androgens, not to mention if you're on anything like if you're anything like me over here, you probably don't want to just be on the aspirin. But this is not medical advice. It's got to be man per man. But let me go into what I see, because when you do a deep dive on this, it's very complex. So I broke it down to a very simple thing here. There's a low molecular weight Lovenox that can be used right after the surgery, right? Now, the bottom line is after the surgery, within 12 to 24 hours, up to 10 to 14, up to 30, 35 days. Again, there's controversy on this. When you implement this right after the surgery, no, you don't take it before the surgery. You're not in the OR. You're not on these anticoagulants in the OR, okay? You start them 12 to 24 hours after, right, and the doctor knows what to do. What I would go for now, I like low molecular weight heparin, Lovenox, but there's some wound issues with that. My doctor told me it's fat. He didn't want to be on this video, but he's a great doctor, and I thought that was interesting that he's super smart, super experienced orthopedic surgeon, and he thought Lovenox was not the drug of choice. It has been in the past, and again, it's man per man. And he thought that Eliquis, guys, 2 drugs, Eliquis and Xarelto, okay? These are direct oral anticoagulation. These are you're going to see these are very special drugs. Those 10A inhibitors in this hypercoagulable state. This is, again, you have to think about risk of bleeding. But what I would go, if I have to go back to the OR, I'm going for the bottom line. In my opinion, what I'm going to do is I'm probably going to stop the Vascepa, but I'm going to start it I'm going to start it right after I have the surgery. I waited. I wasn't back on it, okay? And I would do everything else here that I did, but I would go Eliquis 2.5 twice a day, and I'm going to do it for 30 days. Now that I've had a pulmonary embolism, let me show you this. There's data that I found. Again, this is evidence-based for you guys. This is a New England Journal of Medicine from August 30th, 2025, fresh off the press. Apixaban for extended treatment of provoked venous thromboembolism, New England Journal of Medicine. For men and women that have enduring risks, factors, typically we have a provoked DVT or venous thromboembolism, a DVT or a PE. It's provoked. Oh, we know we provoked it. There's no really underlying risks inherently. So once that provoked issue goes away, we could stop the prophylaxis 3 to 6 months. That's where I am right today. That's where I am right today as an internal medicine doctor with the hematology doctors that I've talked to, and I've known this for years. Now I'm going to stay on a low dose of Eliquis for the rest of my life, probably, unless I have some bleeding risk or something happens, because I'm going to have enduring risks. You see, I'm getting older. That's an enduring risk to me. I'm going to be on testosterone. I like to play with sundry little baby doses of androgens because I just love that, right? Because I'm mitigating the risks. But this is my life, right? Not your life. I don't really have the erythrocytosis from androgens, but I have to watch that because I'm on Jardiance. And I love Jardiance, okay? Now, this is your life. You have to understand it. And everything else is complex. You see that? But I feel comfortable that this data, I want you to look at this data, and you'll see that for up to 1 year, there was versus people that didn't do it, they had more protection, and there was low risk of bleeding for adverse events and bleeding. Remember, if you're going to thin the blood, you're at risk for bleeding. That's it, guys. I really hope you enjoy this and you understand it. I'll close on this right here. If you want to do an H&P, you have to understand your risk for hypercoagulable state. You have to really understand your family history. If you want to do a hypercoagulable workup, here are the labs. Factor V mutation von Leyden. There's prothrombin risk. There's that G7, G202, 10A, the antithrombin, the homocysteine, which is incredible. There's the protein CNS and antiphospholipid antibody. That's a hypercoagulable workup. I'm not going to do the hypercoagulable workup because I've never had to do it before, and I think it was provoked on top of my enduring risks by getting older, being on androgens, and being on Jardiance, and having some androgen-induced erythrocytosis. Maybe I'm going to phlebotomize a little more, guys, but I don't want to throw the baby with the bathwater. If you phlebotomize too much, you lose your iron and you feel terrible. This is not easy to do. It has to be done man per man, fingerprint medicine. That's why I'm here for you guys. Get a lot of questions right here. Get a lot of comments, please, guys. I'm here. The Lord is allowing me to stay. I'm moving forward stronger than ever to help you guys, training testosteronologists. If you're a healthcare provider and you think you have what it takes to come under my training and our training with our incredible testosteronologists, you could see them on the profile. Go to Testosteronology, find a provider. Those are the chosen ones. Those are the testosteronologists that I'm training in the world. We want every country to come on board for anyone that is on androgens, from steroids with harm reduction to straight testosterone for men and women, of course, that are appropriately using it. This is the future in progression. It's very progressive movement for people understanding you don't hate on them. You don't discriminate. We use data. We use as much data as we can. We need more research and we need to move forward because being on androgens can be beautiful if you're an adult. I don't want kids on androgens. You got to be really careful. And I hope you guys can support me on this and give great comments, and just with the grace of God, we can just all keep moving forward together. Because when I was sitting in that fire truck and I was sitting there just sucking wind, I prayed to God and I said, God, please let me get through this. And I thought about doing the video and how can I get through this and help more and more people, to show people, men and women that are on androgens, how they can be as strong and healthy as they can sustainably. Thank you so much, guys.